So I'm going to speak about observation services, observation care. This is a topic that can get its own conference. It's worthy of its own conference, and if you need more information, I'll have some resources at the end where people can go. As I mentioned my talk this morning, I'm on the Scientific Advisory Board of United Healthcare, and I've received grant funding from a couple of agencies, but I don't have any conflicts of interest around this topic. So we're going to review the concept of observation medicine and ED observation units. Most of the talk will focus on the billing and compliance regulations regarding observation care and observation units. And the reason why I want to focus on that is because from a organizational and operational perspective, that really is important in how you set up your staffing, your OBS unit, your pathways, because ultimately it is going to be important to get reimbursed in those. And then we'll talk briefly about several clinical conditions where observation unit care is changing and where there's evidence for it. So raise your hand if your hospital, anywhere in the hospital, has a dedicated unit for observation care. How many do not have a dedicated unit for observation care? Okay. So among those who have a dedicated unit for observation care, in how many of your hospitals is that staffed or managed or run by the emergency department? So not all. So there are some in whom it's not. And this gets to the second question, which is how many people have an ED OBS unit that is run by emergency medicine and staffed by emergency providers? How many have an observation unit that's the ED observation unit? It's run by emergency medicine, but it's not staffed by emergency physicians. It's staffed by internists, PAs, someone else. A couple. How many have an observation unit in the hospital that's not staffed by emergency medicine at all? So that seems like the largest group. And then we've already gone over who doesn't. So it's a key concept, and most people here know this, is that observation is a status or a place of mind. It is not a place. Observation care can be given anywhere. It can be given it is an outpatient code in an outpatient setting. It can be given in a doctor's office, for example, chemotherapy infusion. It can be given in the emergency department, the long chest pain evaluation with stress tests, or it can be given up on the hospital ward as care that many people, particularly patients, would perceive as inpatient hospital care. So we're going to go over the CMS definition and some coding and billing specific issues. It's the natural partner of emergency medicine, and there were a number of pioneers: Lou Graff, Steve Bohan, Mike Ross, a number of folks who really developed observation care and emergency medicine over the last 20 years. And what folks realized is that we are very good at the treat and street patients. We're very good at the patients who you look at, and often in the first 5 or 10 minutes, you know they're getting admitted. There are steps you need to do. But that even after our full evaluation with our CAT scans, with our high sensitivity troponins, and all the other things that we have, there is still a subset of patients who we need more time. And that's where the emergency department and the emergency medicine model sort of ends. And so that's where observation medicine begins. If you think about the average ED length of stay, it's 2 to 3 hours for a discharge patient, maybe 5 or 6 for an admitted patient. The average hospital inpatient length of stay is 5 days and falling, with a median of probably 2 to 3 days. And about half of hospital inpatients come from the ED. Hospitals are often not paid for inpatient stays less than a day. So what do we do with patients who need somewhere between 6 and 24 hours of care? And that's really where observation medicine falls in. So I hate reading slides, but I think these next couple of slides are important because the definitions have changed with CMS, and it's very likely in the next couple of years there may be further change and clarification. But in 2009, the CMS observation definition expanded. And this is from the CMS definition. It's a well-defined set of specific clinically appropriate services which include ongoing short-term treatment, assessment, and reassessment before a decision can be made regarding whether patients will require further treatment as hospital inpatients or if they are able to be discharged from the hospital. Observation services are commonly ordered for patients who present to the emergency department and who then require a significant period of treatment or monitoring in order to make a decision concerning their admission or discharge. And so that really gets at the crux of the matter. Observation is about that decision to keep the patient as an inpatient or not. It should not be used for someone who has a prolonged outpatient emergency department visit where you need to run 4 or 5 tests and it may take 10 hours, but you know there is no chance they're getting admitted. And at the same time, it's not appropriate for patients who really need to be admitted as a status to hold them. They're only covered when ordered ordered by a physician, and the decision whether to discharge a patient from the hospital following resolution of the reason for observation care or to admit the patient as a treatment inpatient can be made in less than 48 hours, usually in less than 24 hours. And so you can do observation services up to 48 hours. Most people who've set up emergency department observation units really limit it to 24 hours because from an operational perspective, those longer lengths of stay are very difficult operationally, and it's much easier if you have lengths of stay somewhere between 8 and 24 hours. A 2010 update to the Medicare definition for the facility observation clarified a few other things. So it clarified that a hospital begins billing for observation services as the clock documented time in the patient's medical record, which coincides with the time the observation services are initiated in accordance with a physician's order for observation services. So the key aspect from the ED observation unit is that physician's order to place the patient in observation care. Additionally, there are some editorial changes to the manuals that remove references to admission, observation status in relation to outpatient observation services, and direct referrals for observation services. These terms may have been confusing to hospitals. The term admission is typically used to denote an inpatient admission and inpatient hospital services. For payment purposes, there is no payment status called observation. So I've already sort of contradicted myself. I think of observation as a place of mind, largely because it can happen any pace, but it really is one of the many outpatient services in the eyes of Medicare. So a couple key billing issues for OBS. And these are broken down to professional billing issues and facility billing issues. CPT codes differ for OBS versus emergency department care. And so they're used to report the evaluation and management services provided to patients designated or admitted as observation status in a hospital, and that admitted part is really not in confirmation with the other definitions. It's not necessary that the patient be located in an observation area. It can happen, as said, in a doctor's office, in ED observation unit. It can happen on the 9th floor next to a patient that's an inpatient. And there are several sets of CPT codes to know about. There are the ED care CPT codes. There are then OBS initial care CPT codes, and there are OBS discharge care CPT codes. The OBS discharge care codes are sort of unique in the outpatient setting because really what those are giving reimbursement for is the work of discharging a patient and the work that goes into that. And I'll have a little more information about that. So the initial OBS care has one set of CPT codes. It includes the initial evaluation and management, documentation requirements, and payment levels that are similar to, and they're sort of similar to emergency observation and inpatient CPT codes. When observation status is initiated in the course of an encounter in another site of service, such as in the emergency department, what most of us are doing, that evaluation the H&P from that can count towards the observation status. The observation care level of service reported by the supervising physician should include the services related to initiating observation status, providing in the other sites of service, as well as the observation settings. And the thing to know is that the CPT codes increase in level of work and in reimbursement. And based on the way your unit may be set up and the way that you're billing, the higher level codes bump the lower level codes. So we're all familiar that from a CMS perspective, the ED codes get bumped on inpatient admission, but the same can be true for an observation patient, depending on how your unit is set up and how your providers are seeing patients and billing. So observation discharge care has a separate set of codes. Observation care discharge of a patient from observation status, and these are the things that are included: final examination of the patient, discussion of the hospital stay, instructions for continuing care, and preparation of discharge records. All things that we would typically do when discharging a patient from OBS, but those are important to have in your documentation for a discharge from OBS, because that's what people are going to look at in audits. Observation and inpatient CPT codes recognize the work of discharging a patient. The discharge work is over and above the work of the initial H&P. And we'll explain this when we get into sort of how you can bill these things in a one-day stay versus a two calendar day stay, and what you can do with different types of providers. So another set of CPT codes exists for observation discharge. So this slide was repeated. So the 7 observation CPT codes, there are 2 that go into a 2-day case, and then there are a series that go into a 1-day case. And what these refer to is whether or not the patient's visit crosses the midnight threshold. And for emergency medicine, this is particularly common, because many of our patients show up in the afternoon, we do our workup, and we're going to keep them in OBS overnight. It's not always the case, but very frequently you'll have a less than 24-hour OBS stay that crosses a 2-day calendar line. And so there are different codes that you can use for that. So a couple rules you need to know about using these. The first is you cannot bill a single provider cannot bill 2 and E&M codes on the same calendar day. So if I see Mrs. Jones with chest pain at noon in our ED, she is put in our OBS unit. We do a 6-hour troponin, and we get a stress test. And at 9 p.m., we've been very efficient. She is ready for discharge. I could not bill and be reimbursed for both the ED visit and the OBS care if I'm providing all of that care. So what happens if a patient has both the initial ED care and the observation care on the same day? This violates the same-day rule. What happens if a patient has both the initial OBS care and the observation discharge care on the same day? This would also violate the same-day rule, because there are different codes for the initial OBS care and for the discharge care. So the solution about how you do this, and really, this is sort of in the billing and compliance piece, but it can affect how you set up your OBS unit. The solution depends on how you set up your unit and who staffs it. And so it's important to think about, are the people providing the OBS care and the OBS discharge in the same group, meaning same tax ID, and in the same specialty. And this is using recognized specialty codes. And we'll have a couple examples here. So in the 1-day example, that's someone comes in, starts their ED visit, gets put in OBS, and discharged all within a calendar day. You have to use a combination code that includes both the OBS care and discharge care, and that is reimbursed more than your ED code and will bump your ED code, unless you have set up your OBS unit in a way that you have a separate group of providers. So for example, if you've hired internists to do this, who are going to provide the OBS care. So that's not the way that most ED OBS units have traditionally been set up, but there are a number of places that are starting to do that, where they have their OBS unit, and it may be run by the Department of Emergency Medicine, or it may be run by the hospitalist service, but the physicians, PAs, and folks who are providing care in the OBS unit are under a different business entity and a different specialty. And in that case, you can actually bill for a separate, you can bill, the ED provider can bill the ED visit, and the internist, geriatrician, whoever's staffing the OBS unit can bill the OBS code in the same day. A 2-day scenario, can also exist. Pretty common, someone shows up in the afternoon, we put them in OBS, do a series of interventions, 8, 9, 10 in the morning, those things are done, they're ready to go home. Under the single group providing OBS care, the single emergency department group, you can use 2 codes, because you can get the initial E&M code on the first day, and then you can use the OBS discharge code on the second day. And this is something to think about as you sort of set up your OBS billing. So there are a couple of scenarios. The one physician, 2 scenarios, 1 versus 2 days. The observation code is billed instead of the emergency code if you have 1 physician in 1 day. And the incrementally added work of observation is covered by the observation discharge codes. If you're doing this, you don't need to repeat the initial H&P on all of your observation paperwork. So your observation paperwork needs to include the reason the patient goes to OBS, what the observation plan is. It needs to have progress notes showing that there's been ongoing care in OBS. And then you need to have a discharge note that needs to detail those elements of the OBS discharge piece. A third scenario is the initial emergency department and observation are different physicians. And in this case, so you can imagine there are emergency departments, and Ohio State has one, Rochester has one, where the emergency medicine department business runs OBS, but the actual providers there are in a different specialty with a different tax ID code. And in that case, they're able to bill both the emergency department visit and the observation visit. In that situation, whoever is seeing that patient in observation, that second physician, needs to do a full evaluation. They need to do a history and physical, and then all of the OBS paperwork. And so these details are important to think about when looking at whatever you currently have and if you're designing an OBS unit. And there's not a one size that works for everyone. If you have a large OBS unit and lots of capacity, then the idea of having a separate set of providers can make a lot of sense, because having internists there, generally their costs are going to be lower than an emergency physician, and you can capture additional revenue. But if you have a small unit, you're probably not going to be able to justify having a separate staff there just for the OBS unit, particularly separate physicians. So a couple of key documentation issues around OBS. It's important to document the H&P. You must include the family history for the OBS codes, and that's not, there are many, for the ED H&P codes for like a level 4 visit, you don't necessarily have to have family history, but for OBS you have to have 3 out of 3 instead of 2 out of 3 for personal, family, and social history. The physician has to order observation for the patient, so you need to make sure that that's included in your workflow, and you need to make sure that that's included at an early stage in the process so that you get appropriate credit. You don't want the patient to be in OBS for 2 hours and then somehow a trigger gets ordered. You need to document the time in observation. This can be done with electronic timestamps. And this is an area that people should be cautious about with auditing. And I'll talk a little bit more about auditing, but there's clearly going to be more focus on auditing OBS in the future. And in particular, the question is someone who's there actually getting observation care, or are they essentially sitting around in a hotel bed, a hospital bed, as a hotel bed waiting for a test? And you can think about a patient who may come in the afternoon with chest pain, and if you've adopted a rapid rule-out protocol with a 3-hour troponin, and they come in at 5 p.m., you might have ruled them out by 9 p.m. But if your stress facilities are not operating 24/7 and you don't have some sort of evening stress test, that patient's going to wait around until 7 in the morning, 8 in the morning, 9 in the morning to get their stress test. And so the question is, if you've done a 3-hour troponin because that's your protocol, and at 9 p.m. they've ruled out, they've got a second set of EKG that doesn't show an active ischemic pattern, and they're not having ongoing chest pain, are they receiving observation care from 9 p.m. till 7 a.m.? It's an existential question. I don't think it's been clearly defined in a CMS transmittal, that exact example, but I could very well see an auditor saying no. They're not. This patient sat there. There's no active care that was being given. And then the other key documentation piece, which I've touched on, is the importance of the discharge summary. Since observation reimbursement is largely about that added work of discharge, you should be doing a good job with discharge, and you should be documenting it. And those are the pieces that need to be there: the final reexamination, the clinical course in the unit, the discharge plan, and the continuity plan. So a couple key billing items for OBS. I think I'm still okay with time, but just of note, the time monitor in the front says 0, and it's been blinking over time. So there have been some CMS facility changes over the last 14 years. It's like every 2 or 3 years, to keep things interesting, Medicare decides to change the rule about OBS. And so before 2000, it was hourly billing based on a revenue code. In 2000, observation was packaged. It was not paid separately. In 2002, it was unpackaged but only allowed for 3 conditions. And people are still pretty familiar: asthma, CHF, and chest pain. And some units still are really designed to take care of only those types of patients. In 2005, the multiple criteria restriction was lifted, and you could use OBS for anything. In 2007, the condition restriction was lifted and folded into a composite APC with the ED or a clinical visit APC. And the question is sort of, what does the future hold? And I can't tell you exactly, but I think it's very likely that there's going to be a major change in OBS billing and regulations in the next couple of years. And I'll get into some of the policy reasons for that in a moment. Some general rules about coding. The OBS definition is the same for the facility as it is for the provider, so that's one area where Medicare is consistent, not always common. It's coded using APC codes. The observation time must be documented in the medical record. Again, it begins with the beneficiary's admission to an observation bed, that physician order to the observation bed, and it ends when all clinical and medical interventions have been completed, including follow-up care furnished by the hospital staff. You can only bill for time when observation is occurrent. A stable patient who is waiting for tests is not technically getting OBS. And hours of OBS reported are done with one of the HCPCS codes, and it can be anywhere from 8 to 48 hours. And so we've recently had to do a lot of work in our OBS unit because we noticed that we had a fair number of folks who were going to the OBS unit for less than 6 hours. They were there for 4.5, 5, 6 hours, and we were not able to really get full reimbursement for many of those patients. And this is probably true in some of your units, because if you have physicians who have metrics showing length of stay, many of those metrics will time out. Your length of stay ends when a patient goes to OBS. And so many of our physicians learned that for that complex patient who needed a 3-hour abdominal CT prep for some reason and then a surgical consult, even though there was a 98% chance they were going to go home, they would put them in OBS because they could stop the clock on the length of stay and really help their metrics. And so that's something to watch out for in your own unit, is this tension between shortening the length of stay and getting people to OBS for enough time. So OBS compliance. OBS has really gotten a lot of media exposure over the last couple of years, and it's not because people generally have been featuring wonderful ED OBS units. It's because there's been a public outcry, particularly in the senior community, over Medicare beneficiaries who go to the hospital, who get put on a regular hospital bed, and then a month or 2 later they get their explanation of benefits and a bill that says that their $15,000 stay requires a 20% copay because they were in observation status, which is paid out of Medicare Part B. And for Medicare Part B, if you don't have a good Medigap policy, you're going to have to pay a copay, as opposed to an inpatient stay, which is under Medicare Part A. And once you've gone over your deductible, that payment, you don't have that 20% copay. And so there have been a series of these cases. There have been a number of newspaper articles in local newspapers, all of the same sort of, here's the patient, and then they show their itemized bill, and it ends up being a huge bill. And the patient, for all intents and purposes, thought they were admitted to the hospital. Either no one told them, or it was not made very clear in the way it was explained. And this has happened enough that there's now a class action lawsuit that is undergoing against Medicare from a group of seniors to whom this has happened. The pressure for hospitals to do this comes from something called the RAC. Who knows about the RAC, the Recovery Audit Committee? So a good number of people. This is one of Medicare's audit programs. It's a bounty hunter system. They have a series of auditors, companies who, this started out in 4 states in 2005 and 2006, and they can retrospectively look at a hospital's admissions and say they did not meet inpatient criteria using the Medicare manual and interqual, and we are going to retrospectively, after looking at 50 of your admissions, we're going to say that 20% of them didn't meet inpatient criteria, and we're going to look at all of your payments for the last couple of years and downgrade 20% of them or 40% of them, and that ends up being a huge hit for hospitals. And so hospitals that have gone through this, big teaching hospitals, hospital systems, have faced multi-million-dollar fines. And so now hospitals are proactively thinking about this, and if your hospital is not already looking at what many people are calling leveling, at the time that a patient's brought in, making sure they're in the right status, inpatient or OBS, you're definitely behind the curve. The third thing that's putting a lot of pressure on OBS is readmissions. So the readmission metrics, these 30-day metrics that were designed to decrease the use of readmission, all count, with the current way they're designed, do not count observation status. So January 1st, grandma comes in for CHF. January 15th, she comes in, she's inpatient admission. That counts as a readmission. If she comes in on the 15th and she stays in OB status, it doesn't count as a readmission. Same bed, same hospital, 36 hours, but just that technicality. And so there's another strong reason for hospitals to do this. So what are the interqual criteria? It's a big, thick book. It's produced by McKesson. It is proprietary. It's subscribed to by payers and hospitals. It's not intended to supersede physician judgment, but it lists specific things that are typical of care that would require an inpatient care. So for example, a patient with pneumonia would need to need inpatient status. They would need to be getting IV medications, IV infusion, and have certain vital sign abnormalities. It's used by case managers and used by the RAC retrospectively. Of note, it's not supposed to supersede the Medicare hospital manual, which is supposed to be, the CMS hospital manual is supposed to be the gold standard. And this is the definition out of the CMS manual. I'm not going to read through it, but it's a little bit broader, and that is the ultimate CMS authority. So what about inpatients who don't meet inpatient criteria? A physician may order a beneficiary to be admitted to an inpatient bed, but upon subsequent review it is determined that the inpatient doesn't meet those criteria. There is a way to go back and put the patient in OB status and not be at risk of the fury of the RAC, but the danger of that is that you lose whatever time elapses until that administratively happens, and you can't bill anything for that. So if I put at 6 p.m., if I put a patient with COPD inpatient status, and the utilization review comes around at 7 p.m. and says, Jay, this patient doesn't meet inpatient status, change them to OBS, well, we can put them in OB status and we've only lost an hour. But if nothing happens until 7 the next morning, then you can't do any billing for that 12 hours. And so if your hospital is not already aggressively working with you and your physicians at the point of admission, it's something to approach them about, because you should be doing that. And it's something that we need to learn as emergency physicians, is a little bit more about this decision. And it's not necessarily a great use of individual physicians' time if you have a good case management system. But if you don't have that system, it is worth learning that and engaging the hospital so that the emergency department is seen in a positive light as the people who know this best, rather than being penalized. So a couple of these Medicare OBS issues. As multiple speakers have said, cost is the overriding challenge of our time. And for Medicare, and for the nation as a whole, hospital services account for about 1/4 of the national health expenditure. It's a higher proportion for Medicare. The single most expensive thing any emergency physician does on their shift is click that box, admit to the hospital, because you can order a whole lot of CTs for the cost of 1 day in the hospital. So it's something that we really need to focus on. Rising volumes of claims for Medicare, and particularly OBS claims, means that something that used to be 1% of ED patients are now rising up to 2, 3, 4%. It's now on their radar. It's a real cost. Additionally, there's been this big rise in the percentage of OBS length of stay that are 48 hours or longer. And these are clearly the sort of abusive cases of people who really are inpatients who have been kept as OBS. And an analysis in 2009 showed that had risen from 3% of OBS cases up to 8%, and it's probably even higher now. We talked about how OBS has cost shifting to beneficiaries, and it has confusing billing rules. So if you're not already doing it, it's critically important that you have a process to inform your patients about OBS. You need to have some standardized language. You need to have a handout that they get, and it needs to explain that they're going to expect a bill for observation status. I think it's best if that's not done by the physician. I think it really mixes up the physician's role, and then you get, as a physician, in this big argument about where you're going to place people. So if you can have your registration staff or nursing or someone else learn that, that'll be helpful. But however you do it, you need to have that in your ED. We talked about the legal case from patients about cost shifting, and so it's very likely CMS is going to change something about the rules. It's possible they could change the cost shifting. It's possible they could do some sort of bundling. Another big effect is that OBS does not count towards the 3-day rule for skilled nursing facilities, and that's something else that patients have pushed back about. And so that may also get changed. So this would be a whole nother talk, so I'm not going to get into a lot of depth about all of the changes that have happened with different protocols, but there are good resources online, and I'll list those at the end of the talk, but I'll talk about 3 protocols, and these are conditions with good evidence in some of the traditional ED-OU conditions. Chest pain is the most commonly used diagnosis for OBS. Things that are changing are there's very strong evidence for short rule-out times, 3 hours, 4 hours. And if you have not changed your rule-out protocol, I would strongly suggest looking at that. There's also a good evidence that we do too much provocative testing, that in very low-risk patients who have ruled out with 2 sets of enzymes, it is extremely unlikely that you are going to find something that is going to change what you do and intervene on somebody with many of the stress tests that we do. Now, we often do them in a medical legal situation because there's no one else that's going to see them, but there are definite ways to reduce the amount of stress testing. But that leaves you in this quandary if all of a sudden you can now do the OBS pathway with a 3-hour rule-out and no stress test and a quick outpatient follow-up. Are those patients really OBS? And they're probably not. And we've changed our pathway so that we're keeping those patients in the ED. We're taking some patients who used to get put in the inpatient cardiology service, bringing them down to OBS, and moving the whole system forward. CHF historically has been tough in OBS. It accounts for about 10% of CHF volume. Several centers have been very successful and achieved rates of 20 to 25% of their CHF patients in OBS. But some criticism is there's not a randomized trial, and the discharge criteria that you want are not always going to be met, that the recovery is a little bit slower for many of those patients. But with the focus on CMS and the focus on CHF readmissions, it's a very reasonable place to work. But it's something where you can't expect that you're going to get half of your CHF patients there. And it's also an area where you really have to watch for sort of overuse, that there are probably patients who can be managed as outpatients with changes in their oral meds and quick cardiology follow-up, and you don't want your CHF pathway to be filled up with patients who could have been sent home. And finally, geriatric syndromes. There are a number of centers that have opened up either geriatric EDs or have integrated geriatric pathways into their OBS centers. Kevin Baumlin at Mount Sinai is part of the team there that got a, I think, $12 million CMMI innovation grant to work with a number of other centers. But this is a really promising area because so many of our geriatric patients really, we're not done with them after all of our tests. And whether it's reassessment, whether it's just seeing the light of day, whether it's talking to family members or arranging care, there are things that need to be done. And so it's an area that takes a fair amount of expertise that we don't necessarily have in the ED. But if you bring that together, there have been places that have been very successful at implementing this. So in summary, observation is outpatient. Learn the billing rules and design your EDOU and your staffing to meet your needs operationally, but also to get reimbursed. They can definitely be a win-win, both for hospital efficiency and for revenue in the ED. And consider adding new pathways for new conditions. Think about syncope, AFib, and DVT and PE, for which there's very good evidence. Thank you very much.